Horner syndrome, also known as oculosympathetic paresis, is a combination of symptoms that can be produced by any lesion along the sympathetic pathway that supplies the head, eye, and neck. It is characterized by the following features: anhidrosis, which means diminished sweating in response to stimuli; ptosis, which occurs as a result of paralysis of the Mueller's muscle that is innervated by the sympathetic pathway; miosis, in which the Horner pupil redilates more slowly than the normal pupil; and lastly, anophthalmos. The mnemonic for these features is AMPI. Androsis determines the site of the lesion. Let's explain this in more details. Horner syndrome can result from a lesion anywhere along the 3-neuron sympathetic pathway that originates in the hypothalamus. First-order sympathetic fibers arise from the hypothalamus and descend through the midbrain and pons to the first synapse, which is located in cervical spinal cord at the level of T1. Second-order preganglionic fibers exit the spinal cord at the level of T1 and enter the cervical sympathetic chain, where they are in a close proximity to the lung apex and the subclavian artery. It then ascends to the superior cervical ganglion located near the bifurcation of common carotid artery. Third-order post-ganglionic fibers exit the superior cervical ganglion and ascends within the adventitia of the internal carotid artery through the cavernous sinus. The fibers responsible for facial sweating and vasodilatation branch off at the superior cervical ganglion. That is why anhidrosis is not a feature of the post-ganglionic Horner syndrome. The oculosympathetic pathway enters the orbit through the superior orbital fissure along with the ophthalmic branch of trigeminal nerve near the long ciliary nerves. The long ciliary nerves then innervate the iris dilator and Mueller's muscles. The interruption of the sympathetic fibers may occur centrally between the hypothalamus and the point of exit from spinal cord, C8 to T2, or peripherally at cervical sympathetic chain, at the superior cervical ganglion, or along the carotid artery. Depending on the level of the lesion, impaired flushing and sweating may be found ipsilaterally. With central first-order neuron lesions, anhidrosis affects the ipsilateral side of the body. Most common causes are stroke, demyelinating diseases as multiple sclerosis, and syringomelia. Lesions affect second-order neurons may only cause anhidrosis of the ipsilateral face. Most common causes are trauma involving the thoracic outlet or the lung apex, Pancoast tumor, or surgery as thyroidectomy. Post-ganglionic lesions occur after the vasomotor fibers have branched off the sympathetic chain. Therefore, anhidrosis is usually absent. Third-order Horner's disease often indicate lesions of the internal carotid artery, such as arterial aneurysm or arterial dissection, and can occur due to cavernous sinus thrombosis. And it is also a common feature of cluster headache occurring with unilateral eye pain and lacrimation that usually lasts no more than 1 hour. Here is an example of left-sided Horner syndrome.